Good afternoon, everyone. We'll go ahead and get started. My name is Dr. Aaron Barnes. I run the Emergency Preparedness and Response Lab here at the Minnesota Department of Health. That's the lab for the special pathogens, which is what we'll be talking about today. We'll be talking about the rule out procedure and some review of organisms, just to make sure everyone's kind of on the same page. We've found that over time, there's been some protocol drift at some places, which is not too surprising. This is designed to sort of give people a refresher. So we'll go ahead and get started. First slide, please. All right, so here's what we're going to talk about. We'll talk about the list of reportable diseases here at the Minnesota Department of Health. We'll talk about what diseases in general have to be reported immediately by phone, which ones we can wait a business day for, and then kind of how you can find all this stuff. We'll talk about the Federal Select Agent Program a little bit, just to remind people how that works, and talk about what the Tier 1 select agents are, the ones that we're most concerned about. And then we'll review kind of the big ones. So we'll review things like anthrax, organisms that causes anthrax, brucella, francisella, burkholderia, stuff like that. So sort of go through a review process, kind of look at each of those, talk about what they look like on the plate, and then what you should expect in terms of finding out info about them. So, all right, next slide, please. So I'm hoping everybody has a copy of this poster, or maybe 6 kind of posted around their lab. This is kind of our standard one. I think it was last updated, I want to say 2 years ago. Not a whole lot has changed, but if you have one from like 2010, let us know, and we'll get you a new one here. This list, you can also just download it electronically. It's available at that site as listed. So there's 2 categories here. Technically there's 3, but I'm going to ignore the Sentinel surveillance stuff at the bottom here. So there's a list that's in the middle that's kind of a lot of stuff. So that's the stuff we need to hear about kind of within one working day. And it's all the stuff that is has a public health concern associated with it. And so it can be everything from Coronabacter sakazakii, which is only reportable in infants in case it's part of a powdered infant formula outbreak. It includes just a ton of stuff that you would expect. Nothing terribly surprising on that list. The stuff that's at the top is the stuff that we're much more worried about. This is the report immediately by telephone part. A few institutions have a way other than a telephone that we've arranged. Some places have an electronic method for reporting to us, but calling us is always fine. People sometimes ask, what does immediately mean? Okay, so don't go to lunch. If you find something and you're worried about it, let us know as soon as you possibly can. Definitely don't leave it to the next shift or anything like that. Just get us notified so we can go ahead and get working on it. All the stuff that has a little test tube icon next to it, the thing that at this resolution looks a little bit like an eyeball, I guess. Those are all ones that we also need patient specimens for under the Minnesota Reportable Disease Rule. And so those are ones we're going to have to get stuff so that we can do some testing as well. And it's all the usual suspects. I mean, it's anthrax and Yersinia pestis and et cetera, et cetera. Some stuff in there is select agents, some stuff is not, but that's what that is. And the report forms for those are available at that link there as well on our website. Just as a note, there are a couple of interesting things kind of stuck on there that basically give us flexibility when a new outbreak occurs. So there's comments in there that are things like any new thing we haven't put on this list yet. So if you get and this is how we got started with COVID, for example, because obviously COVID wasn't on the list because we didn't know about it until it started popping up all of a sudden. So if you get an odd request for something, that's probably falling under that category as well. Next slide, please. So yeah, this is the reportable disease rule for one working day. So it's arboviruses and CREs, Legionella, malaria, stuff like that. And a bunch of stuff that's sort of select agent adjacent, but not actually select agents. So some of the Yersinias that aren't pestis, for example, fall on here. But a bunch of organisms that we'd like to know about because they have something that could be of concern for the larger population. Next slide, please. And these are all the reportable immediately by telephone. Everything that's in yellow is a select agent. So those have additional reporting requirements. There's going to be additional forms if those are positive. Yeah, let's go ahead and go to the next slide. Okay, so the Federal Select Agent Program, we could spend all day talking about this, but we won't. So this is the law that says these are the organisms that we're going to regulate at the federal level. And these are select agents, so organisms or toxins, which have the potential to have a severe impact on public, animal, or plant health. There's the website that you can go to. This is only a partial list. I think we're up to 63 items on the list now. Many of them, again, very common things that you would expect, psilocentrasis, et cetera, et cetera. But then there's also some sort of more oddball stuff like the genetically reconstructed 1918 influenza virus, So we're getting a little bit out there. And there's a bunch of curious sort of South American viral hemorrhagic fever viruses on there. So a whole range of things. If you go to that website, you can find all 63 of them. Some of them are animal only. Some of them are both animal and human. So next slide, please. Federal Selection Agent Program likes to put out their infographic every year. This is still technically the most complete one, I think, because of the last government shutdown. There's about 230 labs around the country that are registered to be able to hold these organisms. Mostly these are state public health labs and or research institutions. Some of them are federal government. The commercial labs in there, just as an aside, are mostly labs that are either doing vaccine development or labs involved in Botox production, because botulinum toxin is a select agent as well. All of these institutions get inspected, usually twice every 3 years, so about every 18 months. Most of these labs are BSL-3 labs, as ours is, but there's a variety of them. Mostly they like to put out this infographic because there are very few places that get dinged for things. Most select agent labs are very good about both their documentation and in being safe, because if they weren't, they would get shut down. So there's very few actual problems that pop up. Most of them that do are sort of administrative or sort of one-time issues that are relatively minor. So if you're more interested in that, you can go see kind of all that on selectagents.gov. But frankly, I think I presented most of the interesting stuff already. So next slide, please. Okay, so inside that list of 63 organisms or toxins that we talked about on the select agent list, these are the list of organisms that are the tier 1 agents. So these require additional levels of scrutiny and additional levels of care. And these are the ones that are the most at risk of being used inappropriately in a biothreat kind of response and provide a severe threat. So again, the stuff you'd expect, agents that cause anthrax, botulism, the couple of Burkhold areas, some viral hemorrhagic fevers, Ebola, Marburg, smallpox is still on there, as is alastrim, the variola minor, and then Francisella tularensis is on here. There are 2 of them that are USDA select agents, so foot and mouth disease, which luckily we don't have in this country anymore, at least endemically. Rinderpest has probably been exterminated in the wild. I think the last case was in, I want to say 2010, but I wouldn't swear to it. But it's in the freezer somewhere, so it's still on the list. So the reason we mention these is that these have additional scrutiny with them, and there are no exceptions for these. So if you cannot rule out one of these, they have to come to us because we have to do additional testing and or get it out the door to CDC for additional testing there. Next slide, please. All right, so let's talk about some of the organisms that you may run across. So Bacillus anthracis, causative agent of anthrax. This is mostly a disease of grazing herbivores, so cows, sheep, goats, things like that. It survives in the soil extremely well. Spores have been documented out to 99 years, and that's without any rehydration. So pretty much if an infected animal has ever grazed on that part of the soil, you're going to end up with it in the dirt. That's just going to happen. So pretty much anywhere in the U.S. that has had large-scale cattle or sheep or goat production has some anthrax in there somewhere. Some places are much more sort of hot spotty kind of places. Texas is a particular hotspot. But we do have cases in Minnesota. We had cases 2 years ago in far northwestern Minnesota, so Kitson County, sorry. And that was, we think, a farmer digging a new line for, I think, an irrigation system, ran across an old cattle graveyard. So this stuff happens. Luckily, no human cases. So the spores themselves are infectious, but this is not a contagious disease. So if you're treating somebody who has anthrax, you're not going to get anthrax from them. That's coming from the environment. There's 4 kinds. There's a cutaneous form. This is like 95% of cases where it forms a wound on your skin, forms a big black, what's called an eschar. I think I have pictures of that. And those will be, and that's relatively treatable. Often requires surgery, but still it's surgery plus antibiotics works pretty well. Inhalational anthrax is the one that we're really worried about from a biothreat standpoint, because this is very dangerous. Even if you get proper treatment, it's fatal a lot. Gastrointestinals, much less common just because of how our food supply works. We're less likely to have spores in our food. Injection anthrax does happen mostly with IV drug users who are using unclean water sources, because again, it's an environmental bug. But from a biothreat standpoint, we're worried about it because it is both a tier 1 select agent. Those spores survive really well. And we have had cases. I mean, this is what the whole Amerithrax stuff was 25 years ago now. There were 22 infections from that and 5 deaths. We did have an inhalation case, an environmental inhalation case that showed up in Minnesota about 15 years ago. This was somebody who flew into Minneapolis-St. Paul, rented a car for a month, and then they were an amateur geologist. So they just drove around the West, Montana, Wyoming, and the Dakotas, just sort of breaking rocks open and having a good time. But at some point out there, got exposed to some anthrax spores, presented at a hospital in far western Minnesota, and was treated. So you can get inhalational anthrax even just from the soil. Next slide, please. So this is kind of a classic. This is actually a photomicrograph, even though it's a little bit overexposed. So these are aerobic gram-positive rods. They're very large. They tend to be sort of 3 to 10 microns in length. They're extremely square. They have very blunt ends. This is the classic boxcar formation. They often form chains, particularly in fluids. So CSF is a classic place, but they can grow chains kind of anywhere. And they form these spores, and the spores tend to be very central. They're not kind of drifting off to one side or anything. And they tend to be very white. You don't get much stain coming through them at all. So anything that looks even remotely like this used to stop and ask some questions. Even the other environmental bacilli that are sometimes confusing don't usually look like this on a gram stain, although there are exceptions. So I guess what I'm saying is if you see this on a slide, don't immediately assume it's anthrax, but don't assume it's not. Let's put it that way. So these are non-modal, non-hemolytic, and we'll look at that some more here on a Petri dish. Next slide, please. And here we are. So this is what they look like under culture. They have what are called ground glass colonies. I've learned in the last couple of years I have to actually explain that part because not everybody does chemistry the same way that I was taught how to do it. So what you see in the upper right there, this is what's called a ground glass joint. When you have a glass on glass fitting in chemistry, they grind that joint mechanically so that it fits snugly and doesn't leak. And so it's ground. So this is what ground glass means. And I would say about 2/3 of the folks that I've trained in the last 10 years or so haven't known what that is. And I think it's because everyone does microscale chemistry now, which is fine, but I just have to change my terms. So anyway, these colonies that you see in the on the left-hand side that has that ground glass appearance, that sort of rough, pebbly kind of appearance. You can also get what are called comet tails. These are not super common. Maybe 25% of colonies or cultures will do this, but they get these sort of odd comet shapes, commas or comma shapes coming out of them. The real thing is that you get what are called medusa heads. So these colonies are extremely sticky. These are kind of, I mean, they're not quite as sticky as some of your like environmental pseudomonads, but they're getting pretty close. When you pull at them with a loop, they will leave little projections sticking up. That's the medusa head. And they won't fall back down. They'll just stay poking straight up. So the other part is that these are non-hemolytic. These cells grow really fast. You can often see a diagnostic a level of growth within 16, 18 hours, sometimes less. 24 hours, they can be confluent pretty easily. You have to be careful with the non-hemolytic part because if you happen to look at a plate that's a little bit old, let's say you're looking at a 36 to 40 hour plate, you can start to see some things that look like hemolysis, but really aren't. They're just general toxicity because toxins are being produced. But at 24 hours, there should not be any hemolysis at all with BA. Next slide, please. So biochemically, this is kind of what we're looking at. So you differentiate Bacillus anthracis from B. cereus, the causative agent of food poisoning and some other stuff. B. anthracis is non-hemolytic, non-modal. We have some other tests we do here looking at capsule and gamma phage susceptibility that also help differentiate that. This slide is mostly in there to talk about one of the other select agents, which I get calls about a few times a year. There's a B. cereus variety that has picked up the toxin and lethal factor genes from Bacillus anthracis in the soil. So you had, at some point in the soil, you had Bacillus anthracis next to B. cereus. The Bacillus anthracis died. The B. cereus went and picked up those genes and brought them in. So it acts like this weird in-between thing where it's sort of like B. anthracis, but it's also sort of like B. cereus. And so you get this thing of you can have either positive or negative for hemolysis. They're almost always modal. I think there's one case they couldn't quite tell. But the hemolysis stuff starts to throw people because if you have something that is positive for motility but negative for hemolysis, what does that mean exactly? So the key thing here to talk about is that Bacillus cereus biovar anthracis is something that comes from Africa. Used to be thought there was a West African and a Central African version. It's probably all the way across the middle, actually. There have never been any documented that I'm aware of human cases. There's some serologies that suggest this can happen. There have been animal cases. But I get calls from Minnesota labs a few times a year where they say, I can't rule out B. cereus biovar anthracis. Okay, tell me about the patient. Well, they're 80 years old and they've been in a nursing home for the last 5 years. That's not it. Unless the person has had recent African travel, I'm not super excited about this. So now, if they're 80 years old and they just came back from safari in Central Africa, that's an entirely different story. But we have to have some sort of epi data there to sort of make that worth doing. So I understand why people get confused, and I'm always happy to have people call and we can talk about it because every case is different. But in general, somebody who hasn't left the state in a few years, not going to be super excited about that. Next slide, please. Okay, so here's what our flowchart looks like for BA. Just as a reminder, because I've had to remind people of this a few times in the last year or two, all of these flowcharts, you got to start at the top. You can't just start in the middle. So we start at the top and look at morphology and gram stain. So if you have something that has something like what I talked about for either ground glass or comma-like projections or very sticky, it doesn't have to be all those. This is an or thing. It's an and or. You could have all those things. You could just have ones that are sticky and nothing else. That's okay. So if you have that, plus you have very large, squared off, boxcar-like gram-positive bacilli, then you're going to go to catalase. If the catalase is negative, that's not BA. If it's positive, let's go on to motility. All right, if the motility is positive, it's not BA. So go down the whole chart and then go ahead and send stuff over to us if it meets those criteria. We're always going to want to talk about it anyway, just to sort of check results. But that's how the flowchart works. It's pretty straightforward for BA. So non-hemolytic, catalase positive, non-modal. The morphology has to match at least something like that on the plate and by gram stain. Next slide, please. All right, so brucellosis. I leave this one in here to talk about it. So technically, brucella is no longer a select agent, came off the select agent list early last year. Most of the motivation for that was brucellosis cases can be pretty nasty, but they are not fatal. They are rarely fatal, only if they're sort of untreated. And generally, even the morbidity is relatively low. So they don't really meet the criteria of causing severe disease in large populations of people. This is actually probably a good thing. When things are on the select agent list, no one studies them because the documentation and regulatory requirements are too high. So I'm hoping with it coming off that we'll start getting a lot more research into what's going on with brucella, because a lot of the stuff there is very confusing. But regardless, the reason I talk about it here is because it's still an exposure risk and laboratorians are a particular risk. You're roughly 800 times more likely as a laboratorian to get brucella in the US than if you're not a laboratorian. And that's because you get something in, you look at it on a plate, you open it up on the benchtop, and it gets aerosolized, and you get brucellosis. So brucella is a zoonotic disease that can cause human infections. For right now, and this is sort of in revision right now, we basically named all the brucellas after the species that they came from. So melitensis means sheep and goats, suis is pigs, canis is dogs. So they're named after what they came from. Realistically, they're probably almost all melitensis, just in different hosts, but that's getting a little far afield for this talk. The reason they're so dangerous for laboratorians is that their infectious dose is really low. Not quite as low as TB, which is down around like 3, but 10 to 100 is not much. We tend to see this in vets and slaughterhouse workers. We've had a couple of Minnesota cases where people have gone hunting wild pigs from helicopters. Not making that up. One case, they came back from Hawaii, another one they came back from Texas, and they came down with Brucella suis infection. So that's where they got it. So the symptoms are really nonspecific. They kind of look like a lot of other things. People confuse them for TB cases. They confuse them for malaria because it has an undulating fever pattern, a bunch of other things. But it's just because it's off the select agent list doesn't make it any less dangerous for those of us working in the lab. So it's still important. Next slide, please. So this is one of the problems with brucella is it looks like nothing. It's just a bunch of little tiny gram-negative cells on your gram stain. It looks very boring. It looks like every other small gram-negative coccobacillus, and it tends to stain kind of lightly like this. That's it. So there's nothing here that screams, I'm a dangerous organism. But this is one you just kind of have to be careful of. Next slide, please. The other problem is it looks very boring on the plate. It grows kind of slowly. It may not come up in 24 hours, kind of depends on if the patient's been getting antibiotics or if the inoculum was low. It grows well on sheep's blood or chocolate or pretty much anything except mac. But it just doesn't look very exciting. It's these tiny little white kind of cream colored colonies. May take a little longer to come up. This is one of the reasons we sometimes keep plates for 7 days. It's non-hemolytic. It doesn't look very exciting. But if you get something that is a little bit slow growing, has this morphology, you get a very boring looking gram stain, just stop and take a second and say, could this be brucella? If it's not, you didn't lose anything except a couple minutes. If it is, you may save yourself and a bunch of other people an exposure. And we have exposures every year around the state. If you get exposed to a high risk activity in a lab, even if you don't have symptoms, you're going to be getting 6 months of serologics every 6 weeks. So you're getting a lot of blood draws and waiting for a long time. So we try to avoid that, but that's what we do if there's a problem. Next slide, please. Biochemically, I generally think of brucella as the thing that is positive. So it's positive for oxidase and catalase, nitrate positive. It is motility negative. You're gonna have to remember that one. The definitive biochemical test here is urease activity. They're all positive for ureas. Most of them are overnight. 1 or 2 strains can go positive a lot faster, sometimes in as little as 10 minutes. There's some additional complications with brucella around taxonomies. So technically the select agent, or I'm sorry, the reportable disease rule was changed to say we have to get specimens that are brucella that causes brucellosis. At some other point, we can get into why that's necessary. But just because you find something that looks like it's a brucella, we may have some additional things to talk about with you on the phone. So in general, for all these organisms, but specifically for brucella, you don't want to take this out, prep something on the bench and throw it in your Maldi. That's primarily because most people prep their Maldi plates on the bench, and that's a high risk activity. So please avoid that. That's one of those common ways we get a potential exposure. Next slide, please. So this is the rule out chart for, or the flow chart for brucella. So here again, you're starting at the top, looking at something that is kind of slow growing. It might come up in 24 hours, more likely 48. It's non-hemolytic, tiny little gram-negative coccobacilli. Then you're doing your oxidase and catalase stuff. You're doing whatever you do in your lab for ruling out Haemophilus, because that's one that is often confused with it. And then giving us a call and asking us if we need to test this otherwise. Next slide, please. Okay, so as I mentioned, these are no longer select agents, so they no longer require Form 4s. They no longer require destruction within 7 days, but they are still a reportable disease, so we still have to hear about them. They're still a reportable disease immediately by telephone, and we need material. But again, I want to sort of harp on this, that just because the rule changed doesn't change the biology at all. And in fact, in the last 20 years, over 50% of all laboratory-acquired infections have been caused by brucella. It's much more common than the ones we often worry about, like Neisseria and this, that, and the other. But it's a big deal. So that's why we pay attention to it, because we'd like to keep people from getting sick. So we did have a lab alert we put out at the beginning of last year about it. And I'm always happy to chat with people if they have questions. We still do the rule out testing here. There aren't really any commercial options that are easily available quite yet. I expect that'll change in the next few years, although many reference labs have been hesitant to promise that they're going to start testing for this because it's a risk group 3 organism. So it's the sort of thing where they would have to change their things, their procedures as well. So we'll have to wait and see how that pans out. Next slide, please. All right. Francisella tularensis, causative agent of tularemia. We just had a big webinar about this about a month ago, which was a repeat of the one last fall. So it's highly infectious, kind of in the same level as brucella, kind of 50 to 100, or I'm sorry, 10 to 50 organisms can cause disease. Can be fatal, definitely debilitating if you get it, or often is. It is a tier 1 select agent. Originally named for Tulare County, California, so it's a West Coast organism when it was discovered, 1913 or something like that, in a ground squirrel. Tularemia, Francisella tularensis, is interesting because it's a small gram-negative organism, but it's very environmentally hardy. Those are not things we usually think about. I often think about things like H. flu. That's actually really kind of a weenie organism. It doesn't do well outside of its host. Francisella does just fine. This also means you can get this organism via a large number of transmission events. So it's not like E. coli, which is usually oral fecal. You can get this any way you can think of. You can get it from ticks. You can get it from biting flies. You can get it from picking up a dead animal and getting in a cut on your hand. You can breathe it in from the dust. You can eat contaminated food or drink contaminated water. All those are routes you can get sick. This is part of the reason why it's a little bit hard for clinicians to sort of nail this down, because there's so many ways you can get it that they often don't think about it. And that's one of the things we talked about in our last webinar a lot, was particularly in cases where you have kind of intractable cases of community-acquired pneumonia that just aren't really getting better, let's maybe think about tularemia, especially if there was an exposure event potential, because those drugs are completely different. We've had a big increase in the amount of tularemia in the last few years in Minnesota. We used to average around 1 human case a year. Last year we had 12. So they've been spiking. Animal cases have been spiking too. I think this is not just better reporting and better diagnostics. I think this is legitimately, there's more dead animals out there, more dead rabbits. Rabbit populations have been booming. Tick populations have been booming. We've been seeing that in other parts of the lab for other reasons. So I suspect that's just kind of in our future for a while now. Next slide, please. So this is one of the problems with tularemia. Tularemia stains poorly, and when it stains, it doesn't stain consistently. You can get slides of tularemia that are just all gram-negative. That happens. But many times they will look like a mix of gram-negative and gram-positives. And the most common reaction when a lab lead sees this is either A, you don't know how to do a gram stain, your decolorization technique sucks, or you have mixed colonies. And either of those are possible. But you also have to keep in your head, if you see something that's really tiny, a bunch of things that are sort of cocci or coccobacillary, but there's kind of a mix and they stain funny and there's not sure what the gram condition is here, pause and take a second and say, wait a second, could this be tularemia? Could this be Francisella tularensis? Because this is often the early warning sign. So sometimes people confuse it for brucella when it is all gram-negative staining that can also be true. That's one of the other reasons that I want to keep brucella testing in-house here, is that I'm worried that we're going to miss, people are going to send stuff in for brucella testing, but it's actually going to be Francisella, because we sometimes see that. So very tiny cells, extremely tiny cells, funny morphology, stains funny. Next slide, please. So they look very boring on the plate again. In the sense, this is a theme that just because something is a dangerous organism doesn't tell you what the plate looks like. It does require cysteine, so these are going to be grown on chocolate plates almost always. They grow pretty slowly. It's pretty rare to get a nice sort of robust appearance of FT within 24 hours. It can happen, but usually it's more anemic than that. Usually it takes more like 48 hours to come up nicely, particularly if the patient's been on antibiotics. But again, it doesn't look very exciting. These are kind of little tiny white to gray colonies. Sometimes they're a little bit blue. They're opaque. They have smooth edges, none of this fancy ruffling or anything. They're kind of a normal size. So, I mean, just because it's not exciting on the plate doesn't mean it might not be something you need to worry about. So just keep that in mind. If you get something that's only growing on the MAC plate, ask some questions. I should caution against that a little bit, particularly if you've had a heavy inoculum, or if it's coming from a specimen as opposed to a subculture or something. We can and do occasionally see sort of weak growth in the first quadrant on a sheep's blood plate. So don't use that as a definitive test. It's certainly not definitive. But if you only have growth in one or no growth at all in the sheep's blood and it's growing fine on the chocolate, be worried and ask some questions. Next slide, please. Okay, so I said I usually think of brucella as being the organism that's all positives. I usually think in my head of Francisella as being the all negatives. So it's negative for oxidase, motility, nitrates, urea. Urea is the thing that's really differentiating this biochemically from brucella. The catalase one is tricky. We always struggle with categories of things that are neither positive nor negative, but somewhere in between. And this has the standard weak positive problem, which is that it kind of depends on who's looking at it as to if they call it negative or they call it positive or weak positive. Sometimes this is really weak. Sometimes it'll be a bubble forming after 60 seconds or a minute, just one or two. So you got to kind of be careful with that one. But it is formally speaking a weak positive. These, because it's a select agent, these do not identify very well unless you have some extra stuff you've done on your MALDI side. Standard libraries will come up with nothing. The classic Vitex panels just are kind of all over the place. They'll call this H-flu, they'll call this aggregatibacter, they'll call it whatever, but it's not correct. So this is another organism that you're going to want to stop after you've seen the gram stain results and once you've looked at the plates and say, hey, wait a second, let's maybe ask some questions and do some more biochems before we throw this on an instrument, because that could cause some other problems and some exposure issues as well. Next slide. Thank you. So rule out for this is not that dissimilar really from brucella, but again, you're looking for a small flat colonies, slow growing, usually 48 hours or more, requires cysteine, very tiny, gram-negative, primarily coccobacilli, but can be sort of pleomorphic. And the staining is kind of either junky or pretty faint. And then you just sort of move down through your oxidase, make sure it's not H. flu, and proceed from there. But again, and I'll keep saying it, if you have any questions about any of these, just call us. We're happy to walk you through it and talk through stuff. And I'd much rather hear about it and say, no, you're fine. Just go ahead and continue with your testing process because it's probably H. flu than I am somebody calling later and saying, I think we've had 10 people exposed to FT. So next slide, please. Okay, Burkholderia species, we talk about these sort of together. These used to be, they still are pseudomonads. They used to be part of the Pseudomonas group. So glanders is Burkholderia mallei. This is an organism that is primarily a disease of equine populations, so mostly horses. Was eradicated here in the US 85 and 90 years ago. We still do see cases internationally that pop up primarily in Southeast Asia, Europe, Southern Europe, the Middle East. Mostly this is now an occupational disease, so people who work with horses, so vets and slaughterhouse workers, sometimes laboratorians. It is still a tier 1 select agent, and you mostly get this by ingestion or inhalation, though cutaneous can happen. But not a thing we're going to see much of unless we've got somebody coming back from overseas. Burkholderia pseudomallei is kind of an evolving and different story. So this is was originally named because we thought it was going to be similar to mallei. It turns out this is a horribly wrong idea. It has a completely different life cycle, a completely different reservoir. It has nothing to do with horses. It doesn't even really look like the other ones at all. So another case where we named something badly. So this is primarily an environmental bug found in soil and water. People often remember that it's from Southeast Asia, but they often forget that it's also in Northern Australia, so up by the Great Barrier Reef. We've seen a number of cases in the US of people coming back from either camping or snorkeling or whatever, and then they get a cut and they get something infected, or they get a weird sort of respiratory disease that they can't figure out what it is. Pseudomallei often in the respiratory form looks and acts a lot like TB, but of course the drugs don't work because it's not TB. So those inhalation cases can be kind of tricky from a clinical standpoint to sort out because they are weird, and they really do sort of masquerade as that sometimes. I should mention that we're sort of on the cusp of figuring out whether or not pseudomallei is becoming formally endemic in the US. There have now been 3 confirmed and 1 probable case that from people who have all been, I think, the same single county on the Gulf Coast in Mississippi. These have all happened since 2020. CDC and EPA have done a bunch of sampling and found the organism goes down many inches. So it suggests it's been there a while. Probably came in on the transport box or something, because again, it's a soil organism. But we have those cases where there's been no international travel, and yet we have folks with pseudomallei. It also has been a contaminant in some household products. Minnesota had a case about 5 years ago from a contaminated fragrance spray that was sold by a large big box retailer, and it was contaminated at its point of origin in, I think, India. There was a Minnesota case and a couple Texas cases, a Kansas case. So sometimes our long supply chains also work against us in that regard. Next slide, please. So Burkholderia mallei, so these are gram-negative coccobacilli. They tend to be a little bit on the curved side. I mean, they're not curved like Vibrio or anything, but they have a little bit of a kink to them. Either that or they can be, they just have really sort of rounded edges, or rounded ends, sorry. So the opposite of what you'd see in BA, for example. Sometimes their edges are a little bit wavy. Sometimes they sort of stack together in these sort of duplex or triplex kind of setups. Classically in the literature, these are called Chinese letters. I don't know, I guess they kind of look like an ideogram if you look at them sideways. Never been my favorite description of them, but that's what shows up on board exams. So this is what mallei looks like. A little bit of a distinguishing characteristic, but just not a lot to kind of work with there. Next slide. So pseudomallei is kind of different because, of course, pseudo. So these are gram-negative bacilli. They have this kind of classic bipolar, or what's called safety pin kind of staining. You get staining at one end of the cell and staining at the other end. They tend to be a little bit bigger. They do have 2 forms. The smooth form, you can often get sort of filaments. They're not shown here. They can get pretty filamentous, actually, and start looking. This is another reason that you sort of get these weird, is it TB or not things, because you can get sort of long filaments that kind of look like mycobacterial filaments sometimes. That can happen. That's what's called the smooth form. But unhelpfully, they also sometimes have a rough form, in which case they're just scattered all over the place, and they just look like every other gram-negative. So not a whole lot you can usually get off the gram stain unless you're kind of a morphology wizard. Next slide, please. So Malii doesn't look like much on the plate. It's kind of boring. Looks like every other gram-negative rod you're going to find. Grows on sheep's blood and chocolate, and the colonies are relatively smooth. They're relatively translucent, but otherwise they're kind of boring. Not a whole lot to go with here. Next slide. Pseudomalii is a little bit different. Again, of course it is. So they're still sort of smooth. They have relatively uniform edges. By about 48 hours, so these are environmental bugs, and like in many environmental organisms, they can start to look a little bit metallic after a couple of days. So the top one in the top line in the center, the 48-hour on the sheep's blood. This is pretty typical for Malii. You can often get this. It's not quite as metallic-y as a Pseudomonas could be, an environmental Pseudomonas, but it is definitely not just your regular colonies at this point. These morphologies, it doesn't really happen on chocolate. This is mostly an SPA kind of thing. They can start to get kind of dried out and wrinkly kind of between about 2 and 3 days. Again, like a lot of environmental bugs. Do not smell your plates intentionally. Please never do that. But they do kind of have a characteristic kind of musty, kind of earthy smell. They don't smell like grapes like some of the pseudomonads do, but they do kind of smell like dirt. Because honestly, that's why dirt smells. It's because of things like this. So they get kind of musty and earthy after 48 hours. Next slide, please. So biochemically, Malii and Pseudomalii are basically the same except for motility. So Burkholderia Pseudomalii is positive for motility. Malii is negative for motility. Technically, there's some oxidase variation in there as well. Some Maliis can be positive on oxidase. Some of them can be negative. But generally speaking, otherwise, they're pretty similar. Most identification systems can't identify these either. So again, we're going to be going through the flow chart. Next slide, please. So the flow chart for this for Malii is a little more complicated. There's a few more tests. But again, you're looking for something that's kind of growing slowly. 24 hours might be okay. You might need 48. You kind of so Malii doesn't grow well on MAC. It does grow, but usually, but it's kind of a little bit wimpy. But you're looking for things in Malii that are gray and translucent, or for Pseudomalii that are sort of wrinkly after 2 to 3 days. And Malii does grow on MAC and tends to be a little bit musty. We already talked about the morphology stuff there. If you get something that's indole positive, it's not Burkholderia, so you can just move on from there. And if you get something that's catalase negative, it's not. So that's the flow chart for it, for Malii and Pseudomalii. And again, often we get stuff from folks that just, I can't tell which one it is because I can't get a solid motility answer because sometimes they're a little bit wimpy. And so we just need a Burkholderia rule out, and that's fine too. Next slide, please. I said it all in the same one, so we'll move on. Yersinia pestis, so causative agent of plague. We'll cover this just for completeness. We are not a plague state. We don't have, as far as I know, we've never had a positive for Yersinia pestis, knock on wood. That would be a very different story if we were in Colorado or New Mexico, where they have this and it's endemic. So, but just for completeness. So can affect basically every mammal you can think of. Common vectors, obviously rats and squirrels. The one people often don't think of is prairie dogs. And prairie dogs can be complicated because they look cute and little kids like to pet them. Prairie dogs also kind of have a freeze reflex where they can kind of freeze if they get startled. And so kids will run up to them and try to pet them, and then they'll get a bite. And the prairie dog can be infected, or you can get it from the fleas on the prairie dog themselves. Variety of transmission routes. Most commonly, there are bites from fleas and small mammals, but you can get it a variety of other ways too. It's like I said, it's endemic to the Western U.S. It's also endemic to most of Africa, big parts of Asia. There's technically 3 forms. I kind of am annoyed by this. Really, there's the bubonic form, the one everybody expects, where you get buboes forming at large lymph nodes, so big, large, swollen protrusions, classically in the groin, but they can happen in the cervical and neck area as well. Pneumonic plague, which is completely different, where you've inhaled the organism and it sets up a massive inflammatory response, and you get ARDS and all sorts of lung failure kind of stuff going. Septicemic plague is just bubonic or pneumonic that has gone systemic. So you have sepsis from plague. Yes, that's very likely true. Bubonic plague, fairly treatable. Pneumonic plague, fairly not treatable. We treat it anyway, but it's has a very high mortality rate. And septicemic plague is kind of somewhere in the middle. Next slide, please. Cell morphology for these look like every other gram-negative bacilli you've ever seen. They're not very exciting. I will note, and I think I have this in another slide, many times places in textbooks and atlases will show you a very pretty picture with some nice pink staining in it that says, here's some pink purple, here's some blue edges, here's some background. Look at this lovely gram stain. They're often showing you a Giemsa, not a gram stain, and then people wonder why their gram stains don't look that awesome. It's because they're lying to you. I've seen this in several textbooks. I have one or two on my shelf that say gram stain, and I'm like, that's not what that is. But anyway, relatively boring gram-negative bacilli, not much to see here. Next slide. They also don't look like a whole lot on the plate. They look like every other gram-negative that you've ever seen. If you let them grow a little bit longer, if you kind of let them go out to 48 hours, sometimes the colonies, not always, but will start to look kind of wrinkled and kind of elevated. They can start to look pretty irregular. You can see on this plate in the upper, yep, there you go, thank you. In the textbooks and on board exams, they will often talk about this kind of colony as being a fried egg kind of colony. Okay, I'd like it to be yellow if it's a fried egg in the middle, but it's not. That's fine. That's my own prejudice there. The problem is this is not unique to Yersinia pestis. Other gram-negatives do this sometimes too. So, so it's a soft finding. In the lower part of this, the larger slide, the larger plate image you can see there, this is also an environmental bug. So it also produces some compounds that have kind of a metallic look to them sometimes. On board exams, this is called hammered copper. I think that's being a little bit florid in this case. It does start to look a little bit reddish sometimes, or even orangish, but it's pretty mild. You pretty much have to have a really bright light to see anything. And it's not very spectacular. So they pull the best examples for board exam pictures, and everybody else just has to live with what reality is. So, so again, doesn't look like a whole lot on the plate. Next slide, please. Kind of mixed results as you would expect for a gram-negative. So it's oxidase negative, urease negative, motility negative, negative for indole. It is catalase positive. The thing I want to highlight here is that it's not uncommon for automated systems, Vitek and et al., to identify it, but they'll get it wrong. Because this is a select agent, most organisms aren't actually in the database for that. So often what it'll do is come up as being another Yersinia. So it'll come up as Yersinia pseudotuberculosis, or it'll come up as intermedius. Sometimes it'll come up as Shigella. So if you get something where you're like, hey, this could be Y. pestis, the automated ID says Yersinia intermedia, pause for a second. If the person has recently been in hanging out with prairie dogs in Arizona, maybe send it to us anyway. So if you do happen to get a positive ID, that's fine, but we still need to get the specimen and test it as well. Next slide, please. Here's the rule out for it. So again, indole, urease, and oxidase negative, non-modal. I will sort of just throw out there in general, this is an environmental bug. No one does this anymore, but this is an organism that actually grows better at lower temperatures. So it'll grow faster. You'll get nice growth at 24 hours if you put it in at 28 C as opposed to 35 to 37. But outside of research spaces, almost no one's doing differential growth with different temperatures anymore. So just as an aside, can have this sort of fried egg appearance, gray-white, sort of opaque colonies. And don't feel bad if you can't see the bipolar staining with a gram stain, because it almost never looks good unless you use a Giemsa. Next slide, please. Okay, I just want to throw out a few words about botulism, because A, we've had a big outbreak of it recently, and B, I've gotten a lot of questions from people. So from a Sentinel lab standpoint, so from you guys out in the field testing stuff, you're not going to be doing any testing for CBOT. This is going to be something where a clinician is going to call you and say, hey, I need to send this for botulism testing. First couple things to know. A, this is a rule in, not a rule out. So a lot of stuff we end up denying because the patient doesn't have symptoms, or because CDC hasn't released antitoxin, because they don't agree that it's likely to be botulism. There's a whole process for this. So if a clinician calls you and says, I want to send this for testing, you need to say, call NBH first, and they'll walk you through it. Your role will probably be limited to packaging the stuff and sending it to us. And I'm very happy to talk to anybody who calls me and says, what do I need to know about packaging this for botulism testing? Because people interpret what I put on the test catalog in a variety of surprising ways, and we often get very weird things that have to then be kind of rectified at the back end, sometimes with new specimens. So, all right, so that's enough sort of ranting about it. So Clostridium botulinum, this is the primary agent that causes botulism. There are several other species of Clostridia that also can, but that's getting a little too far in the weeds at this point. So these are spore-forming anaerobic organisms that are commonly found in the soil, usually down several inches. Classically, we would see this in adults coming from improperly preserved food. So people who canned their own food and either didn't get it hot enough or it's not acidic enough or whatever. And then in the absence of oxygen, nothing else grows. So the botulinum organism can grow and produce the toxin. That's kind of the classic thing. A lot fewer people can food these days. When they do, it's often not steam canning, so you can put it on the shelf. They're often just doing like refrigerator pickles or something, which is a whole different story. But there are technically 3 different kinds of botulism. So the foodborne source. Oh, and I should mention, this is not just home canning. Every year there are recalls for commercial canning facilities that their oven didn't get hot enough or their autoclave didn't get hot enough for processing their canned meat or whatever, and they have to do a recall for that as well. There was a big one for tuna last fall, for example. So 3 kinds of botulism. Foodborne botulism, which is where the organism grows in the food, produces the toxin. It's preformed, you eat it and get sick. That's what we usually see in adults. There is also wound botulism, which is really horrible. These are cases where someone's using unclean water or getting dirt in their syringe when they're using IV drugs, and those go pretty badly. There's been some batches of like black tar heroin that have been very contaminated. Most of those are in Texas and California. Infant botulism is a completely different disease, even though it has the same organism involved. In that case, so infants don't have any neonates particularly, but infants up to the age of 1 year don't have a functional gut microbiome yet. And so if they get clostridial spores in their system, they just land there and can colonize. As an aside, we all eat botulism spores all the time as adults. And none of us get botulism from that, almost none, because we have a functional gut microbiome. There's no place for them to land and set up shop. But that can happen in infants. This is the reason why we tell parents, like, don't feed any kid under the age of 1 honey, because honey has lots of botulism in it. It's basically concentrated by the bees as they're going around from flower to flower and making honey. But for infants, they eat something or they get something in their system that has botulism spores in it. They establish in their gut, then they produce toxin. That has some clinical ramifications, which we won't go into here. But it's not a preformed toxin in this case. It's the organism that then causes that. The reason this matters and why I've dwelt on it is this is what dictates what kind of specimen we need. So in an adult, we almost always need to test the serum because that's where the toxin is after they ate it. We can test the stool for them. We probably won't, but we could consider it. This is the opposite for kiddos. If you have an infant with botulism, we need the stool, and the serum is kind of secondary because most likely we're going to find it in their stool because they're colonized. The botulism toxin, toxins, botulinum neurotoxins. There are 7 of them, A through G. For weird reasons that are still somewhat unclear, 2 of them, C and D, don't affect people. They just affect animals. It's kind of weird. Most cases are A or B. And this is really toxic. I mean, if you had a gram of botulinum toxin, it would poison 1 million people. That's how concentrated it is. It's one of the reasons that the rules around Botox are so significant and why you're supposed to have a lot of training before you administer it, because the toxin itself is very, very dangerous. So anytime you have something where you think you might have a clinician's telling you they might have botulism, they should call us. We'll talk about it. We'll get it sorted out. We'll get them connected with CDC. And then we need to do rule out testing for those. We have one downstairs we're testing right now that just came in yesterday. So these are uncommon, but not rare. Last thing about botulism, just to reemphasize it again, if you have a case and if somebody's asking you to send something, just call us. Because if you call us, we're happy to talk you through every part of all the weirdness that is submitting stuff for botulism. But if you don't, it's going to cost everybody a ton of time and energy because there's a lot of very specific things about the testing that have to happen. So, okay, next slide, please. Let's go ahead and skip this one. We don't probably have time to go through all of this for the ID stuff. Okay, so we will talk about the culture stuff. This is, again, just for reference for you guys because you're not going to be growing this, but it is an interesting organism. So the culture for these is Interesting, not only is it grown anaerobically, but you get these what are called butyrous colonies. So butyr is Latin for butter-like, or buttery, and they do kind of have a very yellow kind of appearance. They're yellow to yellow-green. On the plate, they form really large colonies. These are often greater than 2 millimeters. They have kind of a wavy and scalloped edge. They do become beta hemolytic, but not until after 24 hours. And they're lipase positive. So when we put them on an egg yolk agar, they get kind of this oily sheen as it's lysing that fat. Classically, and again, this is usually a board exam question, and do not smell your plates, but they very much smell like a horse stable. Sometimes that's strong enough that you can even smell it through a respirator, because those are very small compounds. They have a oval subterminal spore. That's a Giemsa stain in the lower right there. It's not a Gram stain. That's what Giemsa looks like. But they have that very kind of classic drumstick kind of look with the spore at one end. Next slide, please. Big complicated testing algorithm. I'm going to run short of time, so let's skip that part. Just a couple notes about viral hemorrhagic fevers. These come up kind of a lot these days because people travel lots of interesting places. So this is just a very large collection of organisms that lead to viral diseases that have many effects in the body. Obviously, hemorrhagic sounds bad because it is, but lots of viral hemorrhagic fevers have somewhat less distinct sort of presentations. Not every person with Ebola is bleeding out of all of their orifices. That's not how it works. But there's a number of families of viruses here, and the diseases can be pretty mild or pretty severe, depending on which one you have. For example, most people who get dengue don't have very severe symptoms. Some people have extremely severe symptoms of dengue. There's some complicating immunological stuff there, but there's a lot of variation there. On the flip side, pretty much everybody who gets Marburg is not going to do very well. They have pretty high case fatality rates. But common features for VHFs, especially in late stage disease, you're going to have uncontrolled bleeding. You'll have a fever. It's in the name, pretty straightforward. You get sort of multi-system organ failure and damage, particularly respiratory, hepatic, kidney failure. So they're pretty devastating diseases. Most of these are things that we normally think about as being kind of Africa, Asia, South America, depending on which one. So Africa is going to be more things like Ebola and Marburg, Congo, Crimean, things like that. Whereas stuff in the New World and in the Caribbean and in South America, this is going to be more sort of your dengue and yellow fever viruses. But these are spreading around a lot. Dengue has now been found in about, I think it's 120 countries now. So it's not just the usual suspects anymore. I mentioned this also because we also do viral hemorrhagic fever testing here. We don't get a ton of call for it, but we do testing for things like Ebola, Marburg, Congo, Crimean, dengue. So if you have a returning traveler that you're worried about, we can do that kind of testing. It is pretty high consequence stuff. So if we get somebody who says we need to be testing for Lassa, there's going to be a lot of downstream discussion about that because we want to make sure everyone's staying safe. Just as an aside, essentially everybody that shows up and their concern is for a viral hemorrhagic fever, they all have malaria. That's hands down what they're going to have. It may be a pretty bad malaria. We had one last year that was a rule out for Lassa fever that was that they had a pretty nasty falciparum malaria, had some CNS components to that. So they can be pretty bad, but not a viral hemorrhagic fever, just malaria. Next slide, please. Okay, so here's the list of stuff that we do test for. Most of these are not things that we're going to be definitively testing for in Minnesota or frankly in any other state. Most of these are things that CDC reserves the right to do the final testing on. That works when there's not very many cases, as there generally haven't been. The couple things I will note on here, so there are two viruses that are kind of commonly floating around the world that we don't test for, and neither does anybody else except CDC. So Hendra virus, which is often something associated with Australia and horses, but slightly more concerning is Nipah virus, which is in kind of the Indian subcontinent. Reservoirs in bats, but they can contaminate food supplies, particularly things like palm wine, so fermented palm tree juice. But the key takeaway here is just we can test for a bunch of these, not every single thing, but those are the phone numbers for getting a hold of both the biothreat phone on the lab side and for calling the epidemiologists if you have questions about exposures either in patients or in lab staff as well. And there, if I said there was a process for select agents, the process for viral hemorrhagic fevers is much more complicated. But again, we'd rather hear about it sooner rather than later. And I'd rather hear about calls that don't turn out to be anything than to miss one that really mattered. So give us a call if you have questions about any of those. Next slide. So just as sort of an overview, most of our testing for viral hemorrhagic fevers, not all, but most of it's based on a couple of BioFire platforms. We're mostly switching over to the BioFire Global Fever Special Pathogens one, mostly because it covers a bunch of VHF stuff as well as bacterial stuff we may need to sort of rule out as well. And we also like that panel because in addition to telling you that most likely that this patient doesn't have yellow fever or doesn't have Ebola, it'll also tell you that they do have a plasmodium. So it's a nice platform. Brought that on last year, I think. And we've had some older versions of this for several years now. Results are usually coming back within about 6 hours for most of these. And testing is pretty straightforward. We just need a couple of purple top tubes. So EDTA whole blood. And we can run these pretty quickly. So next slide, please. Okay. 3 minutes from running out of time. So my timing is better than I thought. So here's how to get a hold of us. Like I said, there's the Epion call number. This is for clinical questions or reporting of a case that you're very suspicious of. This is who infection prevention is going to be calling, or if you need help with infection prevention. And they answer the phone 24 hours a day. And then there's the biothreat number on the right-hand side. So that's the laboratory side. If you have questions about testing, questions about rule outs, questions about biosafety in the lab, call us. We're happy to talk about stuff, either when a bad thing is happening or before a bad thing is happening. Always like to help people get ready for that stuff as well. So, okay, that should be the end of the slide. So we're at the end of the talk there. Given that we're down to just 2 minutes left here, I think I'll probably ask people to email me questions if they have them. My number should be scattered all over the place here. But give us a ring if you have a question about something. Thank you for participating, and we will send out some more announcements about more trainings probably in the early summer for early to late fall kind of periods. We're going to try to do these a little more often. So, all right, thank you everybody, much appreciated, and we'll go ahead and call it good.